You may begin, Dr.
Okay.
Abdullah. The second part, please. Thank you.
Yes. Okay, doctor. As we discussed, repair is more conservative than replacements of restorations. Either it was a direct restorations or indirect restorations. Many older patients may present with all ceramic or metal ceramic fixed prostheses with chipped veneering porcelain. These restorations served the patient for many years, so they may be reluctant to have their prostheses replaced. Therefore, repair of the chipping or chipped veneering porcelain should be attempted in the first instance of failure before considering replacement the restoration, especially in the cases of older patients. Now, when small chipping occur in an anesthetic area, as we see here in the upper photo, and in the it's an anesthetic area and in the posterior teeth, the easiest way to repair the chipped veneering porcelain is to polish the fractured surface. And polishing is sufficient for in this case. However, in all other cases, including aesthetic areas, as we see here, and in the cases of bulky fracture, two possibilities or two ways to repair the chipped veneering porcelain can be followed. The first technique is to repair the fractured part directly with composite-based resin. The second technique is to prepare the surface of the fractured restoration to receive a new veneer that will be cemented to the old restoration or to the fractured restoration using a resin cement. The process of repair of chipped veneering porcelain is challenging, and the strongest or the main challenge in this process is to provide, or the ability to provide, a strong mechanochemical bond between the resin-based composite or the resin cement and the fractured surface of the restoration, which frequently consists of two different materials. Now, for shear-side repair of chipped veneering porcelain, we need two main steps. The first step is the surface conditioning of the fractured surface, and the second step is either bonding the new veneer to the old restoration using a resin cement or the direct application of the resin-based composite. Now, the appropriate surface treatment of the chipped restoration depends on the type of the material exposed on the fractured surface of the restoration. For glass ceramics, such as lithium disilicate or feldspathic ceramics, we should apply or etch the surface using 2.5 to 10% hydrofluoric acid. However, we should note that intraoral use of hydrofluoric acid is controversial because of its hazardous properties or hazardous effect on the soft tissue. Therefore, the clinician should avoid using hydrofluoric acid if possible, and they should never use it without rubber dam application. After applying hydrofluoric acid, we should apply silane coupling agent on the fractured surface under rubber dam isolation. However, now for oxide ceramics and ceramometal restorations, we should use intraoral air abrasion using 50 micrometer aluminum oxide particle in order to condition the surface. Okay. Then we may apply acidic monomers such as 10 MDBs and 4 metals, or we can use the silane coupling agent after shear side tribochemical coating. Okay. Now, age-friendly prosthodontic solutions for elderly patients. Prosthodontic treatment planning in older patients is managed by several factors, including age-related factors such as multimorbidities, manual dexterities, and reduced adaptability or reduced cognition كمان or impaired cognition. The prosthodontic treatment planning in elderly patients is managed by the general health of the patients and the financial means of the patient. Given the increased multimorbidity in older patients, it's logical to switch to a prosthesis that is easier to handle in order to facilitate the hygiene care of the oral cavity and of the prosthesis, and in order to facilitate the maintenance of this prosthesis. Furthermore, older patients may need to modify the restoration later on to accommodate the decreased dexterity and other comorbidities such as a cognitive impairment. So we should consider that with time, the patient status may deteriorate. So we should provide the patient with a prosthodontic treatment planning based on these knowledge or on these concepts. Now, we can classify the prosthodontic solution for elderly patients based on the number and the prognosis of the remaining teeth into partially dentate patients with teeth of good prognosis, partially dentate patients with teeth of poor prognosis, and edentulous patients or completely edentulous patients. Now, for partially dentate elderly patients with a good prognosis teeth, we may consider removable partial denture or shortened dental arch as a treatment options. Now, for removable partial denture, ideally, cobalt chrome framework should be preferred over acrylic removable partial denture in older patients, unless tooth addition or transition, which called the transitional removable partial denture, is planned later on. So the cobalt chrome framework is favored for the older patients. Now, when we compare the cobalt chrome framework with the acrylic removable partial denture, the acrylic removable partial denture gain the retention through extension over the soft tissue or engaging the within the embrasure space. So it's less hygienic, and because it is a mucosa supported prosthesis, it may cause trauma to the soft tissue. However, on the other side, cobalt chrome removable partial denture minimize the gingival coverage and enhance the patient tolerance for the prosthesis. Also, it's more hygienic, and the teeth can provide partial or complete support for this prosthesis, thus reducing the risk of soft tissue trauma compared to the acrylic removable partial denture. So in elderly patients, cobalt chrome removable partial denture is preferred over the acrylic removable partial denture unless tooth addition later on is planned for the patient. No. Older adults have different functional needs from young patients, so they do not usually require a complete natural dentition for adequate function. This concept is usually known as functionally oriented treatment planning in elderly patients. Therefore, shortened dental arch concept was developed in 1981 by the Kaiser to establish the treatment plan for partially dentate individuals. The shortened dental arch concept has been successfully used in older patients by preserving anterior teeth in preference to molars, which are more difficult to maintain. Furthermore, the World Health Organization suggests that adults who retain a healthy functional dentition of at least okay functional dentition معلق كأنه functional dentition of at least 20 teeth usually from second premolar to the second premolar in both maxilla and mandible do not require an oral prosthesis to replace the missing teeth. However, the shortened dental arch concept should be considered only if the patient is satisfied with the appearance and the function of their dentition. So, in elderly patient, we should follow functional oriented treatment planning, and we should consider the shortened dental arch in these patients. Now, many patients do not have the required number of contacting teeth to fulfill the shortened dental arch concept. Therefore, the dentition may need teeth replacement to restore the shortened dental arch concept. So the idea here is that the patient is old in age and he is partially dentate with teeth of good prognosis. However, the number of contacting teeth is less than the shortened dental arch, which is from second premolar to the second premolar in both arch, as we mentioned in previous slide. Therefore, in this case, we need to restore the dentition to align with the shortened dental arch concept. This is generally known as the functionally oriented treatment planning. Now, functionally oriented treatment option to restore the shortened dental arch include resin-bonded fixed dental prosthesis, conventional fixed dental prosthesis, and dental implants. Now, resin-bonded fixed dental prosthesis is considered a conservative and functionally oriented treatment option in older patients because it needs fewer appointments. It's more conservative than conventional fixed dental prosthesis. Also, it has a positive impact on the oral health quality of life of the older patients. Now, fiber reinforced composite resin bonded bridge can be made both directly by the clinician or indirectly in the dental laboratory. Moreover, a combination of both direct and indirect technique can be used in order to optimize the adaptation to the existing situation and to create a successful restoration for the patient. Fiber reinforced composite resin bonded bridge in general has less favorable prognosis than metal framework resin bonded bridge. However, the relative ease of repair and extension is necessary أو خلينا نحكي إنه if we need to repair or to extend the restoration, we can use the fiber reinforced composite, and this advantage compensate for the less favorable prognosis compared to the metal framework resin bonded bridge. Now, a case report of functionally oriented treatment planning. A 67 years old patient with a shortened dental arch and missing maxillary first premolar. Here, the patient has a shortened dental arch with a missing second first premolar. So we need to follow a functional oriented treatment planning for this patient. So they decided to restore the second premolar using a fiber reinforced composite resin bonded bridge, and after they fabricate the bridge, they cemented it using resin cement, as we see here in this case. So in such cases, especially if the patient doesn't have any functional or aesthetic concern or complaint, here we should restore the patient to achieve the shortened dental arch concept, and any further treatment may be considered as an over treatment for older patients. Now, for partially dentate patients with teeth of poor prognosis, here the aim of the treatment in general, or in older patients, is the transition to edentulousness. Now, transition to edentulousness in certain clinical situation, it's very likely that the older patients will eventually lose all their natural teeth, such as in the cases of questionable patient motivation, advanced periodontal disease, advanced tooth wear, and poorly controlled caries. Therefore, the dentist should recognize when the poor prognosis or when the long-term poor prognosis for the dentition or خلينا نحكي when the prognosis of the dentition is hopeless, and plan for gradual transition to the edentulous state. The transition to edentulosism in older patients can be done using either transitional removable partial denture or tooth supported overdenture. Now, The transitional removable partial denture should be designed to minimize the soft tissue coverage and to ensure that the prosthesis is retentive, stable, and cleanseable. A poorly designed transitional removable partial denture may cause the patient to reject any removable dental prosthesis later on. Now, after a suitable transitional period, usually 6 months is enough, the clinician may convert the transitional removable partial denture to a complete immediate denture. Okay, this is the first way to for transition to edentulousness. The second way is the use of tooth-supported overdenture. Providing an older person with his first complete denture can be difficult experience for both patients and the clinician. Therefore, one possible alternative to complete tooth loss is to retain several strategically positioned teeth and use the overdenture. Tooth-supported overdenture have proven to be successful, especially in the mandible, where bone resorption can compromise denture stability and retention. Overdenture have several advantages, including preserve alveolar bone, enhance support and retention, maintain proprioceptions, and psychological benefit of the patient or to the patient. Now, patients for planning for tooth over denture require a careful assessment of potential abutment teeth. The prognosis of the abutment teeth that will be used as an abutment for the overdenture should have a good prognosis, and any teeth with root caries or restoration below the gingival margin or with bone loss exceeding 30% should not serve as an overdenture abutment. So in conclusion, the abutment teeth for tooth-supported overdenture should be favorable. Now, endodontic treatment is required for the overdenture abutment teeth. After completing the endodontic treatment, we should prepare the abutment teeth into a dome shape with a minimum of 3 millimeter supragingival tooth structure, as we see here. The edges of the preparation should be rounded and the center of the dome should be flattened, as we see here in the photograph. Also, it's important not to reduce the abutment teeth to the level of the gingival margin, as this will lead to the gingival inflammation when the denture cover the abutment teeth. This will exert pressure on the gingival margin and will result in gingival inflammation and periodontal disease. Okay. It's also important not to under-prepare the abutment teeth, as this will weaken the acrylic or the overdenture and make it susceptible to fracture later on under function. Now, when a regular tooth preparation is not possible due to the presence of previous restoration or caries, a cast gold coping can be used, as we see here in the lower photograph. Now, finally, caries and periodontal disease are common problems associated with overdenture abutments. Therefore, intensive oral hygiene and maintenance program is required and should be maintained, as we will discuss later on in this presentation. Okay. Now, tooth-supported overdenture, the use of attachments can be considered to enhance overdenture retention in cases of severely compromised retention, elderly patient with complete denture for the first time, patient with poor neuromuscular control, such as Parkinson's disease or post-cerebrovascular accident. Commonly used attachment systems for teeth-supported overdenture include ball attachment, locator attachments, bar attachments, magnet attachments, and telescopic crowns. Although the evidence suggests that these attachments are equally effective, some authors suggest that patients with reduced periodontal support should use magnets or magnetic attachment because they exert the least force on the periodontium. So in the cases of periodontally compromised teeth, the use of magnetic attachments is favorable. Now, for fully edentulous patients, complete denture is one of the treatment options to restore the patient function and aesthetic. Successful provision of complete denture can be challenging, especially in older patients with xerostomia, poor neuromuscular control, and dementia. However, many patients can be successfully managed using conventional complete denture when especially when the fundamental prosthodontic principles are applied. Care should be taken to ensure that denture are well extended, especially in the mandible, and that balanced articulation has been achieved. Special impression techniques, such as neutral zone impression technique, should be considered in older patients with poor neuromuscular control, such as Parkinson's disease and post-cerebrovascular accident, as we mentioned above. Also, in patients with poor neuromuscular control, we should consider copying the existing denture that have proven successful. So, in older patients with older patients that is satisfied with the existing denture, we may copy the denture and no need for new denture. Okay, or we may use the CAD/CAM technique for copying the denture, directly. Now, the second treatment option is implant retained prosthesis. With the increasing predictability of osseointegration, there has been a shift toward a routine use of implants to stabilize complete removable prosthesis. However, providing implant supported prosthesis involve more complex and lengthy treatment procedure than providing a conventional complete denture. Elderly patients suffering from any conditions that preclude implant placements or minor surgeries. For example, patients who are taking bisphosphonate medications, radiotherapy, patients with poorly controlled diabetes mellitus, or patients immunologically compromised. These conditions may preclude implant placement at the same time. However, it's not absolute contraindication. Okay, therefore, a careful planning is always required prior to implant placement in older patients. Now, according to the McGill's consensus in 2002, the evidence suggested that two implant retained mandibular oval denture should be considered as the first choice treatment for edentulous patients. Several studies have evaluated the survival rate of implant supported overdenture. The overall survival rate was 95% in the maxillary arch and almost 100% in the mandibular arch. Now, what are the advantages of implant-supported prosthesis? The advantages of implant-supported prosthesis includes that it's the simplest implant-supported prosthesis. We only need 2 to 4 implants. Okay, it reduces the residual ridge resorption. It's improved the stability and the retention of the denture. It's improved the function and aesthetics. And finally, it is possible to incorporate the existing denture into the new prosthesis. Okay. Now, the components of implant-supported overdenture include implant fixture, acrylic denture, and the attachment system. In 2005, or we will start talking about the implant fixture in 2015. Bryant et al. Conducted a 5-year randomized clinical trial to determine whether 1 or 2 implants should be used for mandibular implant overdenture. However, there was no significant difference in the satisfaction or survival rate of edentulous subjects, either with 1 or 2 implants. Although the evidence-based studies have shown that 2 implants are sufficient to support mandibular overdenture, more implants can make the attachment of the denture more rigid, which would help to retain and stabilize the prosthesis. Accordingly, usually the use of four implants with a bar attachment increase the support of the mandibular overdenture. However, such rigid denture is not recommended in elderly patients with poor manual dexterity because the rigidity of the restoration. Now, the use of or the use of short implants usually shorter than 7 millimeter in length in the mandible with marked bone resorption has been demonstrated to have a good stability and high survival rate and minimal complication. Furthermore, other studies have demonstrated that the use of mini implants less than 3.5 millimeter in diameter in the mandible with a marked bone resorption shortens the treatment time and improve the overdenture stability as evidence in compromised geriatric patients. So we may consider the use of short implants and mini implants in geriatric patients. Now, the attachment systems, including ball attachment, locator attachment, magnetic attachment, bar attachment, and telescopic attachments. Now, ball attachment is the simplest type. It doesn't need a great prosthetic space. Usually, it requires 7 millimeter of vertical space. It allows hinge and rotational dislodgement. Implant divergence should not exceed 30 degrees. Now, for locator attachment, it could be an external retention or internal and external retention, as we see here in this figure. This figure represents the difference between the external and internal retention locator attachment and the external retention locator attachment. Okay. Usually, attachment do not need a large prosthetic or vertical prosthetic space. Ball attachment requires usually 7 millimeter, and implant divergence should not exceed 20 to 40 degree. Depends on the type of the retention. In external internal retention, locator attachment, usually 20 degree can be tolerable. Okay. However, in the external attachment, it allows for more implant divergence, usually 40 degree. Now, for magnetic attachment is simple and comfortable system. However, it has a weaker lateral stability and retention. And usually they are susceptible to corrosion by saliva. However, a new generation of rare earth magnets or magnetic attachment should or could improve their properties and avoid salivary corrosion. Usually, for patients with poor muscular control, such as in Parkinson's disease, magnetic attachments may be recommended. Now, for the bar attachment provide the greater retention, better force balance by its splinting effect. It can correct severe implant divergence. However, it needs a larger prosthetic or vertical prosthetic space. Usually, it requires 13 to 14 millimeter. It is associated with a risk of mucositis due to an inadequate oral hygiene under the bar. Therefore, it's not recommended in patients with poor manual dexterity because it needs the patient with a good manual dexterity in order to maintain the hygiene under the bar. Now, for telescopic attachment is an excellent retention or provide an excellent retention as a result of the friction between the crown and the sleeve, as we see here. This is the crown and the sleeve inserted inside the complete denture. So this friction improve the retention. Also, it provide a better force distribution due to the circumferential relation of the outer crown to the abutment. Also, it has a self-finding mechanism which facilitates prosthesis and insertion. Therefore, the system is effective for geriatric patients with poor manual dexterity. Okay, we talked about this presentation. Okay, now a prospective study. Okay, yeah. No, okay. Technical complication. Now, technical complications with implant-supported overdenture, the most common technical complication with implant overdentures are loosening of the retentive mechanism, usually seen in about 30% of the cases, a fracture of the retentive anchor, occlusal screw loosening with bars, and fracture of the acrylic base plate material. Therefore, prosthetic maintenance is always needed with all attachment systems. A prospective study in 2019, Baker et al. Conducted a prospective study to assess long-term, 20 years on 20 years, clinical, radiographic, and patient-reported outcome of an elderly population provided with mandibular implant-supported overdenture. A total of 53 elderly patients aged 60 years or more were provided with two implants supporting a mandibular overdenture and a maxillary conventional denture. A total of 15 patients completed the 20 years follow-up period, and the 20-year implant survival rate was 92.5% in geriatric patients. Now, we start talking about teledentistry. Teledentistry for remote monitoring of geriatric patients. According to the American Teledentistry Association, teledentistry is the use of the interactive audio, video, and data communication to provide and support dental care delivery, diagnosis, consultation, treatment, and education. Teledentistry provides important oral health service, particularly to older adults and those who are homebound or living in care facilities. Now, the benefit of teledentistry include improved dental hygiene, save the time and money, and the broadness of the access to the care. Now, Dentalo is an online website that provides several virtual services for the patients. It's considered one of the teledentistry websites. Okay, the virtual services they provide for the patients, including online prescriptions of medications, emergency dentist, second option dentist, which considered one type of consultation, yani, photo consultation, and video consultation. Usually, the prescription, they placed $1 for 1 day and $49 for month. Okay. Now, personalized oral hygiene program for elderly patients. Older oral hygiene in geriatric patients require more attention than other age groups. Older adults are at risk of tooth-related disease such as caries and periodontal disease and various oral lesions such as oral candidiasis and oral cancers. Therefore, we should carefully develop and apply measures to protect the oral and the dental health of geriatric patients. Such measures are regular dental examination visits and preventive oral health care, encourage patients to brush and floss as much as physical condition allow, teach the correct cleaning techniques to the patients and his or her caregiver, and a continuous follow-up. دكتور بس باقي دقيقة راح يفصل علينا بتوقع. Okay. Now,